It's my pleasure to introduce Dr. Albani, who is the Medical Director of Neurointerventional Surgery at ChristianaCare. She is board certified in neurology, radiology, and neuroradiology, and completed her medical training at Georgetown School of Medicine. She completed residencies in neurology and neuroradiology at the Cleveland Clinic, where she also completed a fellowship in neurointerventional radiology and diagnostic neuroradiology. She is also the founder of the Neurointerventional program here at ChristianaCare. So welcome, Dr. Albani.
Good afternoon, everybody. Good morning. Not really sure what time it is these days. So yeah, I'm live. You know, this is kind of nice. I'm going to talk a little bit about thrombectomy, which is the mechanical removal of clots. And I wanted this to be kind of a little informal because we don't get a chance to kind of be together very often. So it's nice to be able to have some feedback from the audience. So there'll be a quiz. All right. I have no disclosures. So the objectives of the talk today really are to give a little bit of a background of pathophysiology of acute ischemic stroke, really as it pertains to endovascular therapy, to discuss decision-making, particularly in mechanical embolectomy, discuss the role of imaging and how it's really changed the landscape of what we do, and explore current endovascular practices in stroke treatment. So what is a stroke? There's a clinical presentation of stroke, which we all know, right? There's the hemiplegia, the face droop, that sort of stuff, stuff we can see. And that can be either caused by bleeding within the brain, it can be caused by blockage of a blood vessel in the brain, but it can also, strokes can also be silent, meaning if we get an image and we see a little hole in the brain, not that we ever want to say any part of our brain is not important, but sometimes a stroke can happen in a portion of the brain that we don't really notice. And those are more silent, but they still are considered strokes. So stroke as a term is it's kind of an umbrella term under which there are subtypes. The ischemic stroke types, which is the vast majority of strokes, which is what we're going to be talking about today, comprise about 87% of that. The hemorrhagic strokes, which we won't be talking about today, are a smaller subset. The ischemic strokes are usually thrombotic, embolic, or hypoperfusion. Hemorrhagic strokes are usually from intercerebral hemorrhage, interventricular hemorrhage, or subarachnoid hemorrhage. So the ischemic stroke causes are pretty variable. The most common is cardioembolic. You can also have small arteries that just shut down, what we call lacunar infarcts. You can have, say, a vessel in the neck, for example, your carotid, it has some disease in it, clot forms there, and then goes downstream, what we call an artery-to-artery embolus. You can also have hypoperfusion, where the vessel here in the neck gets really, really narrow, and you just don't get enough pressure to get blood to the very distal aspects or the furthest aspects of the blood vessels, and you can get some strokes as a result of that. And there is a large portion or a moderate portion of strokes that we see that are cryptogenic, meaning we really don't understand why they've happened. So when we talk about ischemic strokes, these blockage type strokes, particularly when we're talking about reperfusing or opening up these blood vessels, we talk about an infarct core and a penumbra. So the infarct core is what happens when you have an abrupt occlusion of an artery, where the blood flow is reduced to the point below a critical threshold that the cells can be viable. This is a region of maximal insult, and this area is where the cells become irreparably damaged. What I like to term the dead plant, right? So these cells, no matter how much water or blood you put back, this ain't coming back. It's dead, right? Versus the penumbra, which is the area surrounding that core that's getting some blood supply, enough to keep the vessel, enough to keep the cells viable, but not enough to make them behave normally. So when you look at a patient, they'll have a profound deficit, even if the core is small. If the penumbra is large, those cells are not behaving normally. So it's going to look like that whole territory is gone, right? But a large portion of that may be salvageable if I can get normal blood flow back in there and perk those blood vessels up, or the brain up again. And one of the things that we found is the viability of those brain cells has to do with collateral. So if there is blood flow that's getting in there and helping and sustaining those cells, if we can get that blood back, they'll perk back up again. So the collateral supply is really key here. All right, so this is what we call the wilty plant, right? So if we can get blood back in there, we can perk that brain tissue back up again. These are just examples, angiographic examples. I don't know why this is going so fast here. It's got a mind of its own. Hold on a moment. So here you can see this blood vessel it has a cutoff right here, right? And this area is pretty devoid of any blood vessels. In this picture, you can see this is further on in the image. This black portion here it's not black on angiography. I put the little black dot there. That's what we consider the core infarct. But you can see the blood vessels are starting to wrap around into this area that had been absent or empty before. And again, you can see that here, how it's kind of wrapping around and helping to feed that area. Even though that area, when you look at this patient clinically, that brain tissue is not functioning normally. Again, here you can see a very similar picture. The vessel is occluded here, but you can see these vessels, these collateral flow coming in and starting to feed this brain tissue in this region. Again, the idea of this core, the core infarct, that brain tissue that's not coming back, but this area of penumbra that's potentially salvageable is what we're going after. And what you'll see as we talk about this is the advanced imaging that we do now really allows us to get a better sense of the difference between what's core and what's penumbra. That is to say, it helps us stratify patients much easier to who's going to benefit from this kind of intervention and who won't. What we do know is that the longer we wait from the time of ictus, or the time that the patients develop their symptoms, to the time that we reperfuse, the patients don't do well. So the longer the time that we wait, the less likely the patient's going to do well, meaning that penumbra will start to die. So again, this is a hyperacute emergency. We want to make sure that we get patients on the table and treated as fast as possible to save as many neurons as we can. The quote that we always put is about you have a reduction of about 10% in good outcome every 30 minutes that passes. So again, it's very, very important to act. The old idea of time is brain. Switch to this. So the first thing that we do when a patient comes in is that, and I'm sure Dr. Morris talked about that, they get evaluated in the emergency department, the neurologist gets involved, and then we get some imaging. The first thing that we do is a good old-fashioned non-contrast head CT. Very, very important because not everything that looks like a stroke is a stroke, right? So you could have a patient who has a tumor, for example, that's behaving like a stroke. They could have some, or seizure, for example, but they could have symptoms that look like a stroke clinically, but it's not really a stroke. They could have a hemorrhage. Obviously, we treat a hemorrhage much differently than when we treated an ischemic stroke. We'd also look for the core infarct on a non-contrast head CT. Sometimes you can see an area of decreased attenuation or an area of darkness, if you will, on the head CT that would suggest that there's, a portion of the stroke that's already completed. And based on those images, we create what's called an aspect score, which is a score that tells us how much brain is damaged. It ranges from 10 to 1. And every area that we see that's dark, that's suggesting a core infarct, we subtract a number. So the lower the aspect score, the worse the stroke is. We also look for something called the dense vessel sign, which here is this bright line here, and that will sometimes indicate where there is clot. We don't see these all the time, but if we do see them, they're quite helpful. Then we get a CT angiogram. The CT angiogram allows us to know as interventionalists if there's something to go after. Is there a target lesion? And in this case, you can see Of course, the right is left, left is right. That's for my job security, just to confuse you. So this patient actually has, you can see here that there should be, like on the opposite side, there should be a vessel here, which is absent. So he has a left M1 occlusion. So that's a large vessel that we can go after and potentially take that clot out. And then we get what's called a CT perfusion. And this will allow us to this is the advanced imaging that I kind of alluded to before. It gives us an idea of what part of that stroke area or that territory at risk is dead, and what part of that territory that I can potentially save. So here in the pink is the cerebral blood flow, which is a good indicator of a core infarct. And then here is the mean transit time, or the Tmax, which shows us that penumbra. You actually subtract this from this to actually get the true penumbra, right? So we look for what's called a mismatch ratio. This ratio here, greater about 1.7, 1.8, to tell us that there's enough penumbra there to go in and take out the blood clot. So what are the treatment options when we decide to treat a patient or not treat a patient? What are our options? Medical management, obviously, if the stroke is completed and there's nothing to do, then the patient will go on for medical management. TPA or TNK, which I'm sure you've heard about already, is the medical management for acute ischemic stroke, or the Drano, if you will, that will help open up blood vessels. And then the endovascular clot removal. And we can also do a combination of both. So the idea or myth that if a patient gets TPA or TNK that they cannot get mechanical embolectomy is not true, right? You can get both, and you can get one without the other as well. So they're not mutually exclusive in any way. So if a patient is a candidate for TPA, they should get it. So talking about endovascular treatment, there's really two approaches. One which is more historical, which is the infusing medicine, called Intra-Arterial Thrombolysis, and then the actual mechanical pulling out of the clot, which is what we do 99.99% of the time these days. The way we do this is typically we'll go through the groin here, and we'll place a sheath there, and then long catheters that go up into the brain. And we either infuse medicine there, or more typically we'll use a device to pull the clot out. We also now go through the radial artery as well, depending on the anatomy of the patient. And we do this in a fluoroscopy suite. Sorry. So this is, again, what we used to do traditionally. This used to take a long, long time. We take a microcatheter, put it into the clot, and infuse medicine. This is intra-arterial thrombolysis. This used to take hours to do. We don't do this very often, and we will occasionally do it in very distal vessels where potentially putting devices out there might injure the arteries. What we do now primarily is what's called mechanical embolectomy. Traditionally, this has been reserved for what we call ELVO, which is the very large blood vessels, the proximal blood vessels. But we're now doing these in even medium and distal vessels that are symptomatic with great success. So lesional aspiration is one of the ways that we do this. It's a brain vacuum. It's kind of like a vacuum tube that we stick up at the face of the clot. We turn on suction, and it sucks in the clot. It either engulfs the clot or just attaches itself to the clot, and then we pull the device out. It's quite cool, actually. Stent retrievers are another device that we use quite frequently, and we use these more for clots that are a little bit more difficult to pull out. They're not responding to the aspiration technique specifically. And what we do is we take the microcatheter, put it actually through the clot, and then we push out the stent, which opens up as we push it out of the microcatheter. We pull the microcatheter back, and the stent will open up in the clot, and it engages the clot. And then typically what we'll do is we'll take the aspiration catheter and come up against the face of the clot as well. So we've got it locked in the stent, and we've got a suction on the end, and then we pull it out. All right, so we're going to do a little bit of some cases here so you guys can kind of get into our brains, which is a little frightening, and sort of kind of walk through how we think about cases, and you know, kind of get an idea of what we do on a daily basis. So the first case is a 37-year-old female who had acute onset about 3 hours prior of a complete right hemiparesis, global aphasia, left gaze preference, and a very high NIH of about 21. So based on the time, she's only been out for about 3 hours. So she is a candidate for TPA, which she did get. And based on the profoundness of her deficits, we're really concerned that she may have a large vessel occlusion and a big devastating stroke. This is her her head CT. Does anybody see anything abnormal here? The dense MCA, right? That's the radiologist sign right there. So yeah, she's got a dense left MCA, which is kind of what we would anticipate based on her clinical findings. In fact, when we did her angiogram, this is shooting from the lateral side of her head. And this is the internal carotid artery as it comes up through the skull base. This is the posterior cerebral artery, which is fetal here. But you can see this cutoff. She should have this whole area here should be filled with blood vessels, which it's not. So she actually not only had an occlusion of her MCA, she had an occlusion of her ICA at the very end of it, what we call a carotid T occlusion. These are very deadly. We went up with aspiration and we were able to revascularize this whole territory for her. And she did quite well. She ended up with small infarcts here and here, but did quite well. She regained her speech, regained function on the right side. She did quite well. In fact, this is one patient who we had put to sleep for her procedure. We extubated her after the procedure, and when she woke up, she looked at the anesthesiologist. She said, "What's going on?" And the anesthesiologist started crying because when she came in, she couldn't speak, she couldn't move. It's one of the very, very rare cases that happens, sort of the Lazarus effect. Second case is an 87-year-old female with a known history of atrial fibrillation who had actually come off of Coumadin for a dental procedure, unfortunately. She woke up, she had gone to sleep and woke up in the morning with some profound symptoms with a very high NIH of 25. But again, this is a patient who woke up with his symptoms. And traditionally, when patients would wake up with symptoms, they couldn't get TPA because they were out of a time window. And traditionally, they couldn't get mechanical embolectomy again because they were out of a time window. But those time windows are sort of going by the wayside. We did a non-contrast head CT. And again, you see that bright vessel here in that right MCA. Her CTA again showed that there's no blood vessel. This blood vessel on the left side is not there on the right. She had a right M1 ICA occlusion actually. And her perfusion, again, when we look at the core versus the penumbra, you can see that there's a lot more area at risk than there is core. So this is a patient who has a nice mismatch ratio that we felt we could reperfuse effectively. And this is a patient who has an ICA occlusion. I'm not sure why I picked all ICA occlusions. Anyway, so she has an ICA occlusion here. We went in with lesional aspiration. We're able to suck that clot out and again, regain good perfusion in the anterior circulation. And this is, I'm sorry if you guys were eating. This is the blob that we pulled out of the head. Just a warning, I have another one of these, so if anybody is squeamish, I apologize. I should have thought about that, sorry. Third case, this is a 60-year-old female with hypertension, diabetes, heavy smoker, was healthy, didn't see doctors, came in with an irregular heartbeat on examination. She had sudden onset left-sided weakness, hemispatial neglect, forced gaze deviation to the right, NIH of about 18, and about 2 hours since her symptoms began. Again, we see this dense vessel sign on her CT. Her non-contrast CT actually looked completely normal. There was no evidence of any early infarct or anything there. So you can see here, based on this cerebral blood flow, there's really no evidence of a core infarct, but we can see that there is a region of penumbra, right? So there's region that's at risk that has not yet infarcted. So again, when we did the CTA, we can see that there's an occlusion here at the distal M1 segment on the right. At angiography, again, you can see that there should be a vessel that comes out here. It should look like goalposts, and she's missing one goalpost, one side of the goalpost. And you can see this big empty area. You can also see too this, those collaterals that we talked about as well. Big empty space. I did try to go up with an aspirator here, and the clot would not come out despite my best efforts. So I went ahead and put a stent retriever in. You can see the stent retriever here. You actually see where it wastes here. It kind of gets a little narrower. That's where it's going through the clot, right? So we put the stent distal to the clot or downstream to the clot and proximal to the clot, so we kind of squish it in the middle. Gets the maximal amount of pull when we pull these out. And this is the clot we pulled out of her, right? So this is actually, kind of cool because this goes into the those branches, the M2s. When the M1 comes out, it goes into the branches. So you're seeing actually the cast of the branches there as well. And this was the final result for her. So I've made this sound easy peasy lemon squeezy. Like this is pretty simple to do, but this is major brain surgery, right? And things can go wrong. Although very rare that they do, they can. In this example, we had a patient, we were successful, had an ICA occlusion, we were successful in opening up the blood vessel. He did have evidence of stroke before we took him in this region. Although we reperfused and saved quite a bit of the territory, the area that was dead already bled. And this happens because as the cells die, the blood vessels become incompetent. They become like holy, and that's not like a halo holy. They actually start to break down. And when you put blood back in there, sometimes they leak. So unfortunately, this gentleman ended up with what we call a reperfusion hemorrhage. This is another example where we had gone in to take the clot out. And based on the patient's very tortuous anatomy, there was a small perforation of the blood vessel when we were putting the devices out, and the patient ended up with a subarachnoid hemorrhage. She ended up doing fine. And this is actually mostly contrast here, but you can get vessel perforations, you can get vessel tears, those sorts of things as a result of what we're doing. And then there's a situation like this gentleman. This is an atherosclerotic plaque. Here you can see you've got darkness here and darkness there, all the contrast that's going through, but you see this little rock here. This is atherosclerotic disease. Gone after this with everything I knew, ballooning, everything. And despite my best efforts, it would stay open for about 2 minutes and then it would return to this, which is most frustrating. And this is a gentleman that I had to put a stent in to keep that vessel open, which again sounds like a reasonable thing to do. But again, in this patient in particular, he had gotten intravenous TPA. And in order to put a stent in, I have to now give him antiplatelet medicines on top of that, which is very dangerous to do because the rate of spontaneous hemorrhage in these patients is extremely high. So we never like to put stents in patients in the acute setting, but sometimes we have to do that. So, interventional techniques for stroke have really exploded over the last several years. Traditionally, say 10 years ago, most patients who would come to us would not be candidates. And now that paradigm has completely shifted. Most of the patients that come to us now they are candidates for mechanical thrombectomy. And that's really due to, in large part, the use of advanced imaging technology, because that really gives us an insight to what's happening in the brain. I mean, we know when we see patients that some patients we see at an hour after ictus, the brain's dead, right? They have no collaterals, the brain's dead. Some patients we see 7 hours after ictus, and there's a huge penumbra, and there's lots of stuff to save. And whereas in the past, we couldn't really differentiate them very well, we had to use rigid time frames say, well, you're past 6 hours or you're past 4.5 hours, we can't help you. Now we can use advanced imaging to stratify those patients much, much better. So we're able to help patients who wake up with strokes. We've also seen there's a lot of a growing body of data that even in patients with large core infarcts, if there's penumbra to save, that those patients even do better if we're aggressive with them. And given the advances in technology, catheter technology, our techniques, we're able now to go after smaller and smaller blood vessels. So for example, if we, I think 2 weeks ago, I had a gentleman came in with aphasia. He had a receptive aphasia, meaning he couldn't understand what I was saying to him, which is a very, very devastating process. But he had an angular artery that was occluded. It was like a little assassin's bullet right to the artery that went to Wernicke's area. Rather small blood vessel, but it had, devastating injury. So we took him to the lab. We went in and I sucked out the clot, and he regained his speech. So it's very, very small blood vessel, but because of our abilities and our techniques now, we can now get even to tinier vessels and save people's function. So lots of really good stuff. So this is the FAST criteria. I'm sure you guys have all read this. This is the millennial FAST criteria. I thought you guys needed to laugh. Lavender oils are wonderful, but I don't think that they will help you with your stroke. I like to tell people there's the stroke RAP, which is recognize, act, and prevent. You need to recognize a stroke, and the FAST criteria is really quite simple. Quite down and dirty. But I always remind people that these things can happen to anybody. It's not just grandma or grandpa. I mean, the first case I showed you was a 37-year-old female. It can happen to anybody. And unfortunately, in our practice, we're seeing younger and younger patients with these things happening, and really look out for others, right? So even if grandma looks at you, she's like, I'm fine. Sometimes depending on where the stroke is, patients will not know that they've had a stroke, and they won't appreciate that they've had a stroke. So if grandma's like this, dial 911, right? Don't drive her, just dial 911. If it's looking like a duck, it's quacking like a duck, call. I'd prefer to see him in the ER 100 times to none. With that one time I could help and they don't come. So that's really important. And again, time is brain. Even though, I described to you that we can treat people at longer and longer time intervals, that doesn't mean you should grab a cup of coffee, maybe go to breakfast, and then, leisurely bring the patient in. You want to act, because there's no way that you can know in the field if the patient has collaterals or not. You hope that they do, but, again, overall, the data shows the longer we wait, the less likely they're going to have a meaningful recovery. And this is, at this point, dare I say, a treatable disease. And we need everybody's help with that. And then obviously you've got to modify your modifiable risk factors. Watch hypertension, diabetes, stop smoking, that sort of stuff. Questions? Her question was, why do we think we're seeing so many younger people? It's a really good question. I think that a portion of it is that younger people are getting sicker. They're suffering from diabetes and hypertension. Old people's disease is much, much younger, right? I have a friend of mine who's a pediatrician who says what he treats primarily is diabetes and hypertension in his 13 and 14-year-olds, which is horrible. But unfortunately, we're becoming more and more sedentary, and we're becoming fatter and fatter. And those are diseases that are occurring younger and younger. I think that's probably the main reason, to be honest.
There's a question in the Q&A. What was the cause of case 1's occlusion? Case 2 was potentially due to a missed anticoagulation dose. Wondering if you knew what case 1's reason was.
Case 1 had a dissection. The 37-year-old had a dissection. I didn't get into that, but we ended up stenting her carotid and a whole bunch of other things. But she had, she was actually postpartum, was retching, had a bad postpartum sickness. She was nauseated, and was throwing up a whole bunch and ended up dissecting her carotid artery, and then from that ended up with an embolus. So again, it can happen to anybody. Usually
What's
around
the
an
smallest size vessel you can get into these days?
Sorry, thank you. Usually we we'll target like an M3, and when we start getting out that far, we like to see perfusional deficit. We like to see, obviously it has to be clinically relevant, right? And most of the time those patients are not, they may not be candidates for TPA. But yeah, we've gone as far as M3s, and there's a growing body of literature that this is not only safe, but it's very, very effective. And again, if you can spare a patient from a profound aphasia, it's amazing. And for whatever reason, clots seem to find they go to places. I call them the assassin's bolts. They go to the places that you feel, right? To the motor strip, to the language centers, so a lot of times we're quite aggressive with those.
Could you just say a few words about the basilar artery occlusion and your approach to that these days?
So that's a really good question. So basilar artery occlusions, for those that just to put those in perspective. So the basilar artery is, in my opinion, albeit a little bit biased, is the most important blood vessel in your entire body, right? It is the blood vessel that subserves your brainstem, without which, you don't really want to breathe. Your heart doesn't want to beat, all these basic, very rudimentary functions. It's a small piece of tissue, but it's incredibly important. And strokes in this region, even small strokes in this region, are devastating. So when a patient has a basilar artery occlusion, we in some ways throw the book out, meaning we are extremely aggressive with them, because vast majority, the morbidity and mortality of these strokes is huge. Most of the literature that we have on acute ischemic stroke has to do with anterior circulation. When you start reading about this stuff, it's really all focuses on ICA, M1, A1 type of strokes. Basilar artery occlusions, which are rarer, most of us will go after unless there's a profound reason not to, because patients will typically die from these, and if they don't die, sometimes they wish they had. So we will be very, very aggressive with those. There's not, I think we're working on a position paper right now on basilar artery or posterior circulation infarcts and their management. But for the most part, we'll go after those even 12, 14 hours later.